Okay, so musculoskeletal complications, I'm sure many of you have heard of these. So avascular necrosis, we're going to talk about that. Just briefly, what is it? Well, it's death of bone because of loss of blood supply to that bone. Okay, so there's certain injuries such as a dislocated hip. There's actually a bone in your wrist called the scaphoid bone, and if that's fractured, there's a risk of avascular necrosis of the scaphoid bone, and part of the bone dies, and people are left with chronic wrist pain. Okay, and the same can happen to the hip. If the hip dislocates, the blood supply is disrupted, and the head of the femur, the ball there, can undergo avascular necrosis, and it becomes very deformed. Okay. Um, Venous thromboembolism, so development of DVTs, and then the risk of part of the DVT breaking off and becoming a pulmonary embolus. Compartment syndrome, where the pressures in a muscular compartment are going up and not only crushing the muscle, but damaging the nerves and leading to particular symptoms and compressing the arteries that are within the compartment and leading to particular symptoms that we'll talk about. Okay, so remember, compartment syndrome can happen from the inside if there's massive amounts of bleeding or edema within the compartment, or it can happen from the outside, say with a really tight dressing or with a cast that has become too tight because the swelling continued underneath the cast. Okay, or the cast was just put on too tight. A fat embolism is where bone marrow and fat leave the fracture site and travel into the bloodstream and deposit in the lungs, in the brain, in the skin, and we'll talk about that. And finally, osteomyelitis is a bone infection. What's the most common way of getting osteomyelitis? A compound or open fracture, right? Compound and open are the same term. So the bone has been exposed to the environment and has become contaminated, and osteomyelitis has occurred. Sometimes, much less commonly, you can get osteomyelitis by having had a blood infection with bacteria that have then seeded the bone and developed osteomyelitis. That's much less common than getting osteomyelitis as a complication of a compound fracture. Okay, so let's talk about compartment syndrome. I've already mentioned it on other slides, but basically it's increased pressure that's occurred within the compartment. And if you look at the lower image there, those are cross sections of different muscle groups, whether they're in the leg or the arm. And notice how the muscle groups are separated by these fascial linings, and they're in separate compartments. So if there's an injury, whether it's a fracture or a crush injury or incredible amounts of edema within one of these compartments, the pressure builds and builds and builds until the muscle starts to die because of ischemia. The blood supply distal to the compartment, so the arteries start to be compressed, and also the nerves start to die because of all the pressure within the compartment. Okay, so now compartment syndromes do not need to be only from a fracture. As I said, they can be from a crush injury. They can be from anything that's caused increased pressure within the compartment. Okay, so a cast can do it. A very tight wrapping that's not allowing for expansion when edema occurs can cause it. So it can be from an internal problem like bleeding or edema within the compartment, or something external like a very tight wrapping or a cast. Okay, so definitely this is a serious complication of casting, but it doesn't need to be from casting only. And once it develops, the tissue meaning the muscle can start to die in the next 4 to 6 hours, right? So it's pretty urgent to do something about compartment syndrome. So what are the symptoms? Well, typically someone will come in and they'll have pain out of proportion to what you would expect. And if you were to feel the compartment, say it's in the calf, it would be rock solid. It would be really, really hard. Okay. And again, say there's a compartment syndrome in the calf, in a calf muscle compartment. If we were to move the ankle, so we would flex and extend the ankle, that would cause significantly more pain because we're actually stretching the dying muscle within the compartment. Okay? And remember those 6 P's, right? Remember what happens to the limb distal to the compartment syndrome. The pulselessness, the pain out of proportion at the compartment site. So you lose your pulses distal to the compartment syndrome. You'll have pale looking skin because the artery is being compressed. You'll have a cold limb, so poikilothermia or cold limb. You'll start to lose sensation, so you might have pins and needles at the beginning, but that'll progress to loss of sensation. You'll have paralysis because the muscle's dying, so it won't be able to move the limb anymore. So remember those 6 P's, okay? So what do we do? Well, depends what's causing the compartment syndrome. If it's a cast, then we'll cut open the cast and relieve the pressure. So a cast or some kind of tight dressing. If it's a compartment syndrome because there was so much swelling or bleeding within the compartment, then it needs to be opened, such as you see in this image here. Okay, and that's called a fasciotomy, where a surgeon will open the compartment, or a healthcare provider will open the compartment emergently to release that pressure. Okay, and then typically it's just lightly packed, and the compartment is left open until the swelling and the pressure settles down. Okay. So again, big thing for compartment syndrome, the 6 P's, which is the neurovascular status, right? What are the nerves doing beyond the compartment syndrome? Is the patient complaining of numbness, pins and needles, loss of sensation? Are they unable to move their limb anymore because the muscle's dying? So that's the neural part. The vascular, can I feel pulses? Does it look like a pale limb? Is it a cold limb? So all those things are the vascular side of it. Okay, so this is an emergency. This has to be addressed right now. Okay, so a fat embolus, well, this is from a fracture. Okay, so I just mentioned that compartment syndrome doesn't need to be from a fracture only. Fat embolism, they're from fractures, and typically a long bone, such as the femur or the tibia. And when it fractures, it releases the marrow, which is made up of lots of fat, into the bloodstream. And that travels to the circulation and goes to the lungs. Okay? And when it goes to the lungs, typically in 12, 24, 36 hours, you start with shortness of breath, so dyspnea. Okay, and at the beginning, it's hard to tell. Well, why is this person short of breath? But it's one of the things we need to think of following a long bone fracture. Okay, what else do they develop? So those fat globules can get to the brain, and it can lead to agitation, restlessness, confusion. Encephalopathy just means that the brain is not working normally. So all of those types of symptoms of confusion, restlessness, agitation. It can also, those fat globules can block up little capillaries in the skin, and those capillaries break open, leading to petechiae, typically on the upper chest, the neck, So a petechial rash is forming. Okay, so those are the three main ones: shortness of breath, neurological symptoms, and petechial rash. Okay, so how do we diagnose this? Well, it's definitely that you have to think of it, right? There's no one test that's going to tell you this person has just had a fat embolus. Okay? So how do we prevent it? Well, if we can immobilize the fracture, say in a splint or a cast or traction, well, it's going to bring the bones back together, and it's going to stop them from moving against each other. And that's going to prevent more fat from going into the circulation. So just minimizing the movement and manipulation of say, a femur fracture is going to help prevent more fat going into the circulation. Okay? Early surgical intervention to repair the fracture. So you can imagine if you have a displaced fracture, there's marrow that's leaking out into the bloodstream. So early surgical repair, internal fixation to bring the bones back together, okay, and stop the leakage of the fat into the bloodstream. Okay, patients often need oxygen because they're hypoxic or hypoxemic. So they may require oxygen because of their their dyspnea, right? And the last bullet point here: adequate support for fracture during repositioning. Well, that makes sense because if you're moving someone with a fracture, well, that fracture is going to be manipulated potentially and move and release more bone marrow. Okay. Okay, we're almost there. I know this one's been a bit long, but there's lots of information. So the last complication, osteomyelitis, which is typically a bacterial infection of the bone. Okay, and what's the most common cause of it? An open fracture. So what kind of symptoms is someone going to develop from osteomyelitis? Well, typically we know someone's at risk for osteomyelitis because they've had a compound fracture and the bone has gone through the skin. So even if the bone poked through the skin and went back in, we know it's had exposure to the environment and they're at risk for osteomyelitis. So what can develop? Well, you can get more and more pain and swelling at the fracture site because there's infection there, right? So it's not settling down. And typically, a fracture will settle down over days to weeks. You can form connections between the osteomyelitis, the bone infection, and the surface of the skin and have drainage. As you can see in this image here, you can have discharge of purulent drainage from the bacterial infection. Okay? The bacteria can then go into the blood supply. So not only is it draining onto the skin, it's also going into the blood supply and causing sepsis, right? So fevers, hypotension, tachycardia, so they're septic, right? The non-healing ulcers, and what I just mentioned, because of the infection, is chronically discharging pus to the surface. And the x-rays will start to look abnormal because the normal bone is being destroyed, right? So at the beginning, osteomyelitis does not show on an x-ray. So for days to weeks, x-rays do not show osteomyelitis. It's only when the bone starts to be destroyed that osteomyelitis now shows up on x-ray. Okay, so doing an x-ray right away or in a day or two, it won't help us diagnose osteomyelitis. Okay? So we may have to do a bone scan. A bone scan would definitely pick this up. It would light up the area of the osteomyelitis. An MRI or a CAT scan would definitely alert us to potential osteomyelitis. What about other tests? So in terms of blood work, well, typically, because you have a bacterial infection, your white blood cell will be elevated, and in particular, your neutrophils. The ESR, which is erythrocyte sedimentation rate, it's a marker of inflammation, that'll be elevated. So we use those inflammation markers such as ESR and CRP to help us, well, to alert us that there's potential osteomyelitis and an elevated white blood cell count. Now we can also take wound cultures, so we can dab that wound that we're seeing in this image and send it off for a culture to see what's growing. We can also take blood cultures to see if there's any bacteria that are growing within the bloodstream. As I mentioned, the imaging, x-rays, sure, typically it takes weeks for changes to occur on an x-ray. MRI would definitely show it, and a bone scan would definitely show it. What's the treatment for osteomyelitis? Typically it's 2 to 3 months of antibiotics. It's a long time because it takes that long to try to destroy the bacteria that's all throughout the bone. Okay, very hard area to treat. And typically it's IV antibiotics at the beginning, and once we see that it's settling down, a patient can be converted to oral antibiotics. Okay, but some patients go home with PICC lines and they receive IV antibiotics for months. Surgical debridement, where they're going to open up that wound you're seeing there on the left in the image, open it up, clean it out, take away the dead bone that's never going to recover. Okay. Hyperbaric oxygen chambers are where, there's chambers that patients can go into and pressurized oxygen, and that's been shown to improve oxygenation of the tissue and help with the healing of the wound. Okay. Antibiotic beads are just another way of getting antibiotics into the bone. They can plant seeds that are impregnated with antibiotics and put them into the bone. And finally, if it's a chronic osteomyelitis, not healing, antibiotics aren't working, recurrent debridements aren't working, then amputation may be necessary. Okay. So in terms of nursing actions, it's always going to be the same thing. Neurovascular assessment distal to the wound. Do they have pulses? Do they have a normal neurological status distal to the wound? And of course, dressing changes, right? These tend to discharge a lot of purulent material, and so patients need frequent dressing changes. Okay. Okay, so that's the end of the module. If there's any questions or concerns, you can contact me. It's Dr. Karagesian, or contact your instructor. I hope this was helpful. I know it's on the long side. I skipped some things because they concentrated more on them in the textbook, but I think between the textbook and these slides with voiceover, it'll give you a really strong background for musculoskeletal trauma and the other conditions that we spoke about. Okay, see you at another module.